Welcome, everybody. This is a narration of a presentation by Dr. Micheal Negraeff on aging with SCI and pain. This was presented on April 23rd, 2024. Dr. Negraeff introduced himself. He is also a peer, as he's a T4 complete SCI, which he obtained in 1995. He was an anesthesiologist from 1997 to 2001. He then became a pain medicine specialist and was educated in Australia. He has been a VGH physician since 2003, worked on the spine ward and the clinic at VGH until 2019, started a transitional pain clinic in 2018 to now, and has been an active member of the Pain BC Society since 2008. He wanted to make sure that there was a disclaimer that there are no financial conflicts involved in this presentation, that nothing he says is to be taken as medical advice. There is no doctor-patient relationship formed, and don't change any of your treatments or start new ones without first discussing it with your personal healthcare provider. He went into, the first thing he did was go into categories of pain. I may not be able to pronounce these exactly right, but they are nociceptive versus neuropathic. Nociceptive is an injury, a tissue injury, or the cause of a disease. Neuropathic is injury or disease of the nervous system directly. There is a third category called nociplastic, when nociplastic pain undergoes plasticity changes in the CNS and becomes more like neuropathic, or its primary pain problems like fibromyalgia. A couple of questions that were asked by the discussion group were: does neurogenic pain typically increase with age? And orthopedic or injury-related pain, do muscles weaken, making injuries more common as we age? Dr. Negraeff addressed both of these, and basically neurogenic pain does not necessarily increase with age, but it is much more likely that you're going to get injuries and weakness-related pain as you age. Nociceptive pain, this is the pain you are familiar with. As we age, it gets more common. SCI and non-SCI alike. There are degenerative changes with age, wear and tear, tendons, muscles, ligaments, everything kind of ages and gets a little less strong. Some amount is inevitable, but you can diminish the frequency and severity of this type of pain by taking care of your body and regularly exercising. Shoulders and necks tend to be problems for SCI who retain upper extremity mobility to push around, but can be neck, back, hips, arms. It depends on your level and the pattern of your SCI as to where your pain is going to occur. Neuropathic pain. Everyone with an SCI has had an injury to the nervous system, so all are at risk for neuropathic pain. There are two broad types: at level neuropathic pain, which occurs in and around the zone of your sensory level or your injury level. Below level neuropathic pain, occurring 2 or 3 segments or more below the level of sensory change or injury change. At level neurogenic pain often has zapping and shooting characteristics, but can be also a burning sensation, often associated with hypersensitivity to touch or pain with clothing touching you or rubbing. It is often only on one side of your body and often comes on soon after injury. It may go away with changes in the first few months or years, or it could persist. Below level neuropathic pain tends to be more diffuse and on both sides, often from the low back, buttocks, hips, and groin, but can go all the way down to the feet. It's often more burning, buzzing, stinging, pulsing, and really hard to describe, usually in areas that don't have any sensation or feeling. Tends to come on later after injury, sometimes months and even years later. See, this is the prevalence of chronic pain in Canada. And there was a survey done, and the question was, do you have pain? And 44% of the people surveyed said yes. So it's a big problem in our world. Have you had pain for 6 months or more? The answer is yes. There are 35% of the participants in the survey who said yes. And was this pain last suffered less than a month ago? And again, the answer, 29% of the participants, of which there were 445 to 450, said yes. 29% said yes, it was suffered less than a month ago. And several times a week or more, 24%. And with intensity, that was 5 or more out of 10. And that was a yes by 18%. Pain and SCI. Pain is one of the most burdensome conditions after SCI. More than a third of people with SCI would rather get pain relief than gain motor function back. Prevalence of any chronic pain in SCI is 60 to 70%. Prevalence of neuropathic pain after SCI is 40 to 60%. 20 to 30% of SCI have pain that is moderate to severe and greatly interferes with daily function. This is 10 times the average in the general population. Doesn't matter what type of injury pattern, completeness, or age, can't predict who will get pain. The treatments for pain are, there's 4 P's: physical therapy, pharmacotherapy, psychological therapy, and procedural therapy. The definition of pain is an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain is always a personal experience that is influenced by varying degrees of biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves as an adaptive role, it may have adverse effects on function and social or psychological well-being. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. Treatments, meds, and there were a number of questions around this. Nociceptive pain, same as for non-SCI. It's Tylenol, Advil, and other anti-inflammatories, or opioids for acute severe injuries, not so much for chronic pain anymore. For neuropathic pain, the same treatments are the same for non-SCI as well as SCI. Antidepressants like nortriptyline, amitriptyline, or duloxetine. Anticonvulsants, gabapentin, pregabalin, lamotrigine, and topiramate. The pronunciations might not be quite correct. Or IV lidocaine or ketamine, topical creams for hypersensitivity, and again, opioids like tramadol or methadone. Psychotherapy. Chronic pain has enormous impacts on mental health. Poor mental health has negative impact on pain severity, on how we cope with it. It can be very hard to make any progress on improving pain and quality of life if significant depression and anxiety exists. There are many forms of psychotherapy. There are medications, anxiety and depression medications, talk therapy, group or individual, cognitive behavior therapy, acceptance commitment therapy, education, learning, self-management strategies are all forms of psychotherapy. Procedural therapy has a number of ways that can be implemented. Needling of muscle knots, which includes IMS and trigger point therapy. Joint injections, so facet joint in joint blocks, neck, back, shoulder, needling of tendons, tennis elbow, spinal cord stimulators, and surgeries for specific issues. Exercise, and there was a big question about how much is enough or too much. Exercise is very important, not just for pain, but for health and longevity. The single most important intervention for a healthy life is exercise. The body is remarkably resilient and adaptive if you give it a chance. Everything about SCI and exercise needs some tailoring to individual circumstance. Age, ability, level of injury, other injuries, interests, etc. Could really say this about non-SCI, but more variables are existing in SCI. Pain and overall state of health impact each other. Poor health, high inflammation, and inactivity will worsen pain and vice versa. Types of exercise that you can do are aerobic capacity, strength, balance, and flexibility.
So in terms of longevity and what we call health span or a healthy lifespan, aerobic capacity has the highest correlation. The more aerobically fit you are, just in general, the better your health and longevity is going to be in the long run. And you don't have to be super fit. In fact, if you are in the bottom, say 10% or 20% of fitness compared to all people, just by going up from 10% to being in the bottom 20% or the bottom 30%, those are huge gains. So you don't have to go far. In other words, you don't have to be running marathons or, climbing whatever, lifting weights that are super heavy. You just need to get a little bit more and you can make a really big difference. And that will have some effect on your pain. Strength and the amount of muscle mass you have and the strength is the second largest predictor of health and longevity in aging. Now, we're at a disadvantage because right away, maybe half your body or more than half of your body is no longer under your control and those muscles are going to waste away. And there's nothing you can do about that, not very much anyway. So it becomes even more important for us because we want to maintain as much strength and muscle mass as we age as possible. And muscle is where all those carbohydrates and glucose and sugars and things that we eat, muscle is the biggest place where all that sugar goes. And so it's much easier for people who are inactive and have lost muscle after a spinal cord injury to lose a place to put all of those carbohydrates that we eat. And the result is poorer metabolic health and weight gain. And that's not good because that leads to more cardiovascular disease and diabetes. So we're at a bit of disadvantage because we have less muscle mass than someone who wasn't injured. More muscle, the more you have and the more strength, you have better metabolic health, less diabetes, less chronic illness, less injuries, more independence. So some kind of resistance training becomes pretty important for aging with the spinal cord in general. And I think it needs some guidance so that we don't injure ourselves and we pay attention and listen to what our bodies are saying. But we need to kind of chip away at it and continue to do it as much as we can. One way I like to think of it, or I heard someone else say it actually, was what they called the centenarian Olympics, which is what do you want to be doing when you're 100 years old? So I've adapted it to the old age Paralympics. And you have to start and say, what are the things that I want to be able to do when I'm 60, 70, 80, 100, whatever, however many years we're going to be around. And you have to be kind of specific and say, well, you know what? I want to be able to wheel to the grocery store and carry a bag of groceries on my lap or the back or something. Or maybe you can walk still with your injury and you want to still be able to walk a certain distance or climb stairs or get on the floor and play with the grandkids. I don't know. It has to be whatever it is, starting with your capacities now and thinking about what do I want to be able to do 10 or 20 years from now. You kind of define that. And then you go backwards and say, all right, I know that even just aging without a spinal cord injury, or with one for that matter, that I'm going to gradually lose some muscle mass and strength. And it really accelerates after we turn 70. So you need to kind of work at it just to stay where you are. And if you want to be doing even more when you're older than you can now, then you have to be at a higher level. So let's say you want to be able to, I don't know, wheel 3 blocks. I'm just going to put a number out there. I want to be able to wheel 3 blocks around the block and then get home again when I'm 70. Right now I'm 50 and I can only do 1 block. Well, you're not going to be able to do that when you're 70 because you're going to be less capable than 1 block at 70 if you're only doing 1 block at age 50. So I got to be able to be able to do 5 blocks when I'm 50, because when I'm 60, I'm only going to be able to do 4 blocks. And when I'm 70, I'll hit my target of being able to do 3 blocks. So that's the kind of thinking. So it's, again, thinking about what do I want to do? What are the old age Paralympics that I want to be able to participate in? And what does that mean for where I need to be now? So it's a bit of a challenge to think that way. Exercise how-to, I think we already mentioned this, there's no one answer. Physical therapist assessment would be good, setting goals and measuring, do things that are fun. You got to listen to your body about how much is too much and pace it a little bit, but just try to keep making progress. There will be more aches and pains as we get older. There's just nothing we can do about that. All we can do is try to slow it down and delay it. Some exercise, some rest in between is important. And we've talked about overuse injuries a bit already. Okay, alternative approaches, very briefly, because there's just not a lot of evidence here. In acupuncture, most of it, if it's true acupuncture, Chinese medicine acupuncture points, when you compare it to sham acupuncture, there's really not any evidence that it's any better than doing real acupuncture. So the most important thing is it's probably just kind of relaxing and a bit of a stress from pain relief rather than having a very specific effect. Cannabis, there's quite a bit of evidence just in general for pain, and probably THC and CBD are both important components. And I always just kind of say it's a bit of an experiment to try it and just see if you're finding some benefit or not. It's better probably than taking opioids, however. Psilocybin, magic mushrooms, I'm not up to date on this at all. I'm not really aware of any evidence from the past where it was impacting on pain directly. And there's more of a role probably in trauma situations and severe mental states than pain. And distraction, anything you can do to distract yourself from pain is good. It could be just anything, hobbies, reading, audiobooks, videos, games, doesn't really matter. Working for other people, volunteering, mindfulness, these are all helpful. Visual imagery, these can all be helpful. Sleep is harder as we get older, even without pain. Pain's going to make it worse. Sleep hygiene rules become even more important, and these are some examples of them. Go to bed, get up at the same time, you wind down an hour before bedtime, avoid screens, don't drink caffeine in the afternoon, avoid alcohol within 3 hours of bed, etc. These are just some of the sleep medications. Again, you want to do sleep hygiene first, and then if a medical physician or somebody recommends trying some sleep drugs, the ones in the second column here are better to rely on than these ones in the top column. New developments, I scanned the literature very briefly again. There's just not a lot new out there on the horizon other than the stuff we've been doing for 20, 30 years already. There's maybe some of these brain stimulation techniques, but they're just being kind of researched. They're not ready for actual treatment. And I think where we're going to see anything new, it's going to be more along the lines of drugs that directly treat some of this inflammation in the spinal cord that's happening, that's generating it. And like there's been treatments in rheumatoid arthritis and MS kind of problems that are very specific, and we just don't have those yet for chronic pain. But that will come, but it's going to be a while yet, I think. And I've just thrown some resources here. Pain BC Society has lots of great stuff on their websites, and they have some phone lines and coaching programs that you can access. So I'll leave it at that.
Well, opioids. So you're not keen on them being used, and certainly not on a regular basis. But at a recent horrible experience about 2 weeks ago, and the solution was hydromorphine. It brought the pain to a point where I could get back into control again. Is that a recommended thing?
Yeah, was it sort of like a short-term thing? Like it's not like day in, day out for years and years?
It was something that came up suddenly. Yeah.
Yeah. I mean, that's the way we should be using them, is for short-term, kind of break the cycle, get out of it, or deal with an injury, but then wean off of them again. Maybe it's days or a few weeks at most, and that's kind of the work we do for the post-surgical patients too. We try to avoid the day in, day out usage of them for on and on.
Yeah. Thank you.
Michael, it's Linda. I don't have spinal cord injury, but I do have MS. And my only pain is at night. Like during the day, I'm fairly active. I mean, I haven't walked in 30 years, but I'm fairly active. I do some Zumba and I do some wheelchair boxing and I do some band work. But I get pain at night, aching legs and pain at night. And I try not to take medication because if I do that, it's hard to get up in the morning. It you know, if I take too much medication, then my transfers in the morning are a disaster.
Right. Yeah. It's common that people get more pain at night, especially if it's neuropathic pain. And we think that's because we're just not busy at night anymore. We're not distracted. We're not moving around. And so it intrudes in our, thinking and consciousness a bit more. So it's a tough one. I don't know what to suggest. Like medications can sometimes be useful, or maybe it's just a sedating effect and people kind of conk out and don't notice it anymore. But again, that's not ideal, like you said. Sometimes things like magnesium and some of these supplements for sleep can be helpful for that. It's very hit or miss. I don't know. I don't know if someone told you they think it's more neuropathic pain, but I suspect with your MS condition, it probably is. And so it's a tough problem. I hear you. And we don't sleep as deeply as we did when we were younger. So these things, pain at night can really intrude on our sleep a lot more.
Yeah, I just kind of put up with it. I've had MS more than 40 years. And so I've had pain for 30 years. I just kind of deal with it.
Yeah. And things like non-sedating drugs like Tylenol or Advil don't really help that too much for you?
I do once in a while, but again, I'm so drug sensitive that anything I take impacts me.
Yeah, I don't know what else, like warm bath or some, self-massage. I don't know, any kind of relaxing thing may help a little bit, but it's not an easy problem.
How I deal it mostly is when I go to bed, I'll read for an hour or two.
Mm-hmm. Yeah, kind of distract until you get sleepy enough.
And just me.
Yeah. Get a bit distracted until you're sleepy enough and can kind of go to sleep, right?
I'll sleep with my phone on.
Yeah.
All
Okay.
right, Scott has his hand up.
Yeah. I was just wondering, do physicians tend to, if you're experiencing pain below the level of your injury, do they tend to look for or screen out any physiological causes to that, like spasticity or heterotopic ossification, things like that, that would be causing the pain before they default to it being just neurogenic pain?
Yes, for sure. I mean, that people should do that. Absolutely. I mean, there can be certain qualities about the pain that can make it seem pretty obvious that it's neuropathic, but again, still should be asking, like, what else could this be? Yeah, spasticity would be one, ossification or other kinds of joint injury or joint pain problems or contractures could be triggering it. I think I didn't mention this, but it's important, I think, also to know that even if it is neuropathic pain, like it might be obvious that it's neuropathic pain by the qualities and patterns, anything kind of nociceptive that we don't otherwise feel, like a bladder infection, you may not be aware you have a bladder infection until you actually have fever or spastic bladder happening. All of those kind of regular painful conditions are still feeding into the spinal cord. They're still sending signals, even though we're not consciously aware of them, and they can make the neuropathic pain worse. So when I was seeing people, often to be like, you know what, there's this neuropathic pain. It's been the same pattern for years and years and years. It hasn't changed. I know what to expect. All of a sudden, it's kind of worse, and it's gotten. I don't know what to make of it. What do you think, Doc? And I'd be like, okay, well, we should look and see if these other things could be not causing the pain, but making your neuropathic pain worse. Does that make sense? You know what I mean? Yeah. So yes, that should be done. I think people that see people with spinal cord injury a lot will tend to do that, but family physicians or others who aren't so familiar may just be kind of like, oh, that's just your neuropathic pain. And that's not so helpful.
Okay, Roger?
Yeah, thank you, Michael. This has been wonderful. You mentioned it was in your slides, that the cannabinoids were better than the opioids. I'm curious why, and what about long-term or side effects from the cannabinoid type stuff?
Well, I guess I was kind of thinking more that if someone was going to be long-term on opioids or cannabinoids, I'd rather them be on cannabinoids, because the side effects are not as profound in the long run as they are for opioids. Like opioids have a lot of negative effects on like our hormones system, our testosterone, our bone density, not to mention just that they're far more dangerous for overdose, sedation, and potential accidental death. Cannabinoids, that's not really an issue with terms of accidental overdose or dying from that. So there's much greater safety profile. There's other risks, of course. You can develop a cannabis use disorder. It's much more rare than an opioid use disorder, but it is certainly possible. So they're just overall less potent in terms of their side effects. I don't think there's still a lot we don't know about or understand about how well they work in various pain conditions. I think there's a lot more hype than there is evidence to support them. So I think, again, it's like you try it and find out if is it helping you sleep a bit better or helping spasticity or pain, and is that whatever gain that is that worth any side effects somebody might be having? And if it is, you carry on, and if it isn't, you stop them.
So I had never used anything for the last 37 years, but they've had me using tramadol recently. I've had some complications, but unfortunately or fortunately, it seems to work to offset symptoms, not so much the pain, but sweating, all these other things. And I don't take much of it, but I'm just wondering, that versus the other approach.
Well, tramadol is a pretty mild opiate compared to, say, oxycodone or hydromorphone or methadone. It's a much milder opiate, and it has some other effects that are similar to the way the antidepressants work. And so there might be a better role for that than some of the other opiates. And I was treating patients in an era where we weren't worried about opiates for a long time, and we just were giving them out like crazy because that's what we were told to do. And so when that stopped, I was aware of how dangerous it was to kind of pull people off their opiates, even though that was happening. And I recognized too that there are a number of people who've been on opiates for a long time, quite safely, without any problems, who seem to be getting some benefit from them. And I saw no reason to try to accelerate getting those people off their opiates either. So, I think there's a degree of nuance here that I couldn't really convey in this. They're not the be all and the end all bad, evil things. You just have to be careful with them. And I would probably try to avoid sending someone towards them for the long run, particularly the more potent ones now, and try to, use them more intermittently if possible. So kind of get over a bad spot and then try to come back off of them again, partly to maintain that they still work, but also to avoid the longer side effects. But tramadol would be a little bit less concerned about some of the other ones.
Hi, I don't know if people know, but there's a transcutaneous electrical stim study going on at ICORD. So I really want to encourage people to check that out. And, I think, was it originally like the electrical stim, was that actually sort of developed for some pain relief? Or
you're talking about like transcutaneous electrical nerve stimulation, like those little devices with electrodes on the skin? Yeah. And that's been around for a long time, and seems to work for some people when they have some feeling in the skin where it's kind of being applied. It doesn't seem to like change the underlying whatever's going on. So it's probably a little bit more like a distraction and covering a bit of a blocking effect of the pain. And if it works for people and they can kind of manage to put it on and take it off and use it that way, that's perfectly fine. And it's obviously zero side effects sort of thing. The spinal cord stimulator is kind of like taking that and then putting it inside your body, like right on the spinal cord. It's, it's obviously more interventional, but you're getting it right where the nerves are coming into the spinal cord. So that's why it's done. But the idea was kind of similar. And
one other question. So I'm on methadone for pain, and what I found, it did help, or it does help. And then my doctor actually prescribed another pain medication. Jeez, methadone really affects your memory, I think. But yeah, I found I added another one, and it really bumped it down another level for pain.
Yeah, methadone would be one where we probably, if we're going to use a long-term powerful opiate, and methadone is probably a little bit better. It's got less tolerance that develops. It works a bit better in neuropathic pain. So it's just got some unique characteristics. It's got some unique dangers as well. So you have to be kind of monitored for some of that. But definitely, I would rather see someone on methadone for their chronic pain that is sensitive to opiates than say hydromorphone or oxycodone or morphine.
I'm getting older, and I have had a heart attack, and I am on type 2 diabetic medications, and I was referred to an endocrinologist who asked me, am I in pain? And I said, I'm in pain 24/7. I've always got pain. What are you
Yeah.
talking about? He says, no, do you have aches and pains? And I said, I push a wheelchair all the time. I'm 200 pounds. I lift, and
Yeah.
so he changed my statins that they had put me on, which most of all of us probably would end up going on as we age. And all of a sudden, all that achiness went away.
Yeah, were
So
you
how
on
do
like
you?
Lipitor? Was it Lipitor or something, the first one?
It was first one was that, and then it was something else, and then he changed me
Yeah.
to something else. So
Yeah.
how do you distinguish between defaulting to I'm in pain all the time just because I use a wheelchair to the
Yeah.
medications that I'm getting because I'm getting older may be contributing to my
Yeah.
overall sense of aching?
Well, yeah, you raise a good point. And there's qualitatively how it feels is not really any different. You're just kind of achy and sore all over, and you think, oh, I'm an active person pushing a wheelchair, just like you said. And so it takes someone with some knowledge to kind of go, what about this medication? So statins, especially the earlier varieties when they came out, those were well known that a number of people, like 20-30% of people, would have muscle aches and pains, often shoulders, hips areas. And usually you'd see someone who doesn't have a lot of pain, and all of a sudden they're having pain when they started a statin, and it'd be like, oh, right, you're one of those folks who's going to respond poorly to that. And so then either you put up with it or you take them off of it. Now, the newer statins, and I'm not a cardiologist, but I've talked to some doctors about this. I understand that they're much, much better, the newer ones, Pravachol, and there's a couple of other newer ones that they seem to have much fewer side effects for muscle ache and pain, not eliminated completely, but way lower. And so that was your experience, was it, where they swapped you over and you improved? So again, it would have to be a bit someone who kind of knows you a bit more, or maybe you know yourself a bit more, and you kind of see, I didn't have pain, and all of a sudden I have pain, I started this new medication. It's pattern recognition and some knowledge about these drugs.
Yes, thank you. I've been popping ibuprofen a lot over the last few years, and I'm just
Haven't we
wondering
all?
any side effects to that.
Yeah,
Just
so
ibuprofen, not Advil or anything, just ibuprofen tablets.
yeah. So ibuprofen is one of the drugs that we call the non-steroidal anti-inflammatories, and we've had these drugs. There's about 20 different kinds, but we've had them for decades, long time, and they're very potent anti-inflammatories and very potent pain relievers. So that's great, and they're not addictive or anything like that. But unfortunately, they do have a number of side effects that you got to monitor for. And because they are kind of system-wide drugs, they work everywhere. They work in our brains, our kidneys, our heart, everywhere. So some of the ones we worry the most about are gastrointestinal bleeding, because they interfere with our coagulation. And as we get older, we're more prone to bleeding disorders. So having a GI bleed from like the lower part is probably the number one risk, because that can be potentially fatal if not caught. So you want to kind of make sure you're not also taking aspirin and other kinds of blood thinners, or if you're on a blood thinner like warfarin or something, definitely want to discuss taking anti-inflammatories with your doctors. They will lower the amount of blood flowing through our kidneys. And again, if we're healthy, that's not really a big deal. But if you get dehydrated or severely dehydrated and you're also on an anti-inflammatory, that could cause a kidney injury. Now, you can recover from that, but it could be severe enough that it causes permanent kidney damage. So again, got to monitor that. And then the third one would be more along the heart. There was a subclass of those drugs called the COX-2 inhibitors that actually caused an increased frequency of heart attacks and strokes, because it was they block the coagulation, but they can kind of throw the whole system into imbalance a bit and actually lead to more clots happening. And so some people had heart attacks and strokes. That class of drugs, we kind of know about it better, but even ibuprofen and naproxen and other ones can also do that to some degree. So again, it's sort of those three areas: bleeding, kidney health, and heart, that you kind of want to have a discussion with your physicians about, like, am I okay to take ibuprofen once a day or twice a day or 3 times a week with my particular health?
Can that taking ibuprofen and Tylenol and all of they're different. I understand they're different, but do they not also affect your bowels and your bowel management?
Probably not too much. So just Tylenol, first of all, does not have any of those side effects that I just said for ibuprofen, because even though people think of them the same, Tylenol is completely different compared to ibuprofen, and so you don't have to worry about the bleeding and heart stuff with Tylenol. Bowels, they don't tend to mess up constipation or cause diarrhea in the most cases. Now, everybody's a bit different, of course, but that wouldn't be the top of my mind for sure.
However,
I want to point out one thing that was said in the user group discussion that kind of was maybe addressed, but not really. But one person said, opioids, I got pain all my life anyway. So what does it matter if I'm addicted to opioids? Can you respond to that?
Sure. So I think often in chronic pain, the biggest problem with opiates is you take them, you get some relief, and then a few weeks later, it's not working so great anymore because tolerance to opiates is quite strong. So then you got to go up a little bit more, and then things are better again for a while, and you're awake and alert. Then a few weeks later, or months later, you got to go up again. So, and as you get into higher doses, like hundreds of milligrams of opiates, now you're kind of on a knife edge, and it doesn't necessarily take much to tip you over into like a very serious sedative sort of event or respiratory depression. The second problem is if you're on opiates and your system's all kind of tolerant to them and you need a surgery for something else, like got to get your gallbladder out, that's going to be painful, and they're going to give you opiates to manage that pain, but it's extremely much more difficult to manage that post-surgical pain if you're already on high doses of opiates. So that's a bit of an issue. A third thing would be that you're going to have all these opiates around your house, your home. You might have teenagers around or younger people around. They can become addicted even if you're not addicted, because a lot of people take opiates and they're not addicted. It's just they're on high doses and they're maintained on it. So safety for the public is another thing, and your loved ones. And then finally, just all those other kinds of things like osteoporosis and lower testosterone and estrogen. These all have bad sort of effects on our health that have nothing to do with the pain management part of it.
Can I just jump in and make a comment?
Yes.
When you talk about being addicted to the opiates, there's a physiological component to it that when you start to come off of them, you can, go into withdrawals and things like that. Can you not?
So you'd have to wean down slowly, and the longer you've been on them, the harder, the more slowly you might have to do that to come down off the dose, so you don't have a violent withdrawal reaction. Most of the time, withdrawal is not life-threatening unless you came on a very high dose and stopped very suddenly. So typically that's not. But it's just, it can be an issue too. Like if you lose access to them for some reason, you're not going to be in for very much fun when your body's trying to adjust to the lower dose or the sudden absence of it. A lot of diarrhea, aches and pains, and it can be horrible for several days. So yeah, like you generally kind of want to avoid getting on high doses for extended periods of times. And I've seen a lot of people over the years who I thought, they were doing actually okay. Often if they're doing okay, it doesn't take much, like maybe 20 or 30 milligram equivalents of morphine in a day, and they just sort of stay on that. I've seen lots of elderly ladies who are not in spinal cord injury with lots of degenerative arthritis. They were on just a little bit of morphine or a little bit of oxycodone or something, and they stayed on the same dose for years, and they were largely fine, but it was kind of a small dose. So, I'm not like an evangelist, like nobody should be on opiates ever, but I also think we swung too far one way, giving too many opiates. And now it's really got to be very context sensitive, I think.
Hang on.
Oh, sorry, Gordon, go ahead, Gordon.
When I came off hydromorphine, I sort of likened it to coming out of a fog. I became much more aware
Yes.
of everything. But there
Yes.
again, I came down very slowly, like
Yeah, that's very
milligram or
true.
milligram and a half at a time.
Yeah, we've seen that a lot with patients who we kind of, both the patient and me or other thought, you know what, you're not doing too badly, but maybe we should try to come down and just see what happens. And amazingly, sometimes people found their pain was the same or even sometimes better. And suddenly their brain fog lifted and their energy came back. And we're like, wow, it was kind of like that had been there so long, you didn't even know what you were missing anymore. So that's very true. And we've seen that quite a lot with people who've been sort of on high dose opiates for a long time and, carefully kind of coming down and in a very compassionate, slow way. Also saying that, what, if this doesn't work, we're not going to like steal them from you. Like, if it didn't work, it's fine. We've been in this boat for 10 years. We'll keep it going, kind of thing.
Okay.
Duncan, can I ask
Yeah.
a kind of a counterintuitive question
Yeah, sure.
to Dr. Negraeff?
Yeah.
Appendicitis is a pain, what my understanding, it's a pain-dependent diagnosis. You apply pressure to the abdomen, you release it, and you get pain, and you have appendicitis. In a higher paraplegic, how do you diagnose appendicitis when you can't feel pain?
Well, it's a good question. And
I like that question. I've always wondered about that.
Same here. And I'm a physician, but I have a paraplegic injury. And sometimes I have symptoms and I'm like, is that something I got to be worried about? Like, what's, is that like a bad thing that it just doesn't feel like a bad thing because it's not hurting very much? So I think there's two things. One is, if it's going to be a serious problem, you're going to get sick in other ways as well. Now, ideally, you don't want to get so sick that you got to go to the intensive care unit, but with appendicitis in particular, nausea and vomiting and loss of appetite are pretty early signs too. And in fact, those are actually even before you have significant pain. So it's going to become kind of obvious to look for something like an appendicitis once you're having some pain or discomfort or bloating, but nausea and vomiting as well. Now, the second thing is that even though we are paraplegics or quadriplegics in terms of what we feel in our muscles and bones and skin, a lot of those deeper sensations from the viscera, they have other pathways. There's the vagus nerve that's outside the spinal cord. There's other ways that some of these signals get through. In the same way that you can still feel hungry as a quadriplegic, or you might feel something in your lower guts, kind of cramping sensations. So stuff can still get through and be declared when the threshold's high enough. So yes, it can be a challenge and things can be delayed because of that. But I think there's often enough other information and other symptoms that are not pain. But it does require a higher index of suspicion, for sure.
How do you test for those other types or locations below site pain? And what can you say about second or third spinal fractures?
So she's referring to like the below level neuropathic
I don't
pain?
know. She is here. I don't know if she can unmute and clarify the question.
Yeah, hi. It was sort of in reference to what Scott was saying earlier.
Right. About other kinds of pain problems that you maybe don't feel normally. So, yeah, this is why they teach us to look at our skin and do checks and stuff like that, because we don't always feel everything. I've burnt myself. I've had blisters on my toes from a heater and hot coffee spilled. And I didn't even know anything about it. Skin ulcers and stuff like that. These are all things that simply require another level of vigilance that we just have to kind of be diligent about and check even if we're feeling okay before things get bad. because once it gets really bad, if it's something like an ulcer, you may not notice anything until your spasticity changes, or you actually have a fever and you feel crappy. So there's a knowing about it, there's a checking for it, there's an index of suspicion when some new things have happened, like a change in our neuropathic pain, as I mentioned before, or a change in our spasticity, or just some other feeling unwell symptoms like lower energy, whatever. Sometimes we just got to look at this, and we can't rely on our nervous system always to tell us exactly what's wrong. So it's a challenge, and things do get missed as a result, both from the patient not knowing it or not interpreting things, but also physicians not looking very hard or looking hard enough sometimes.
So I want to thank Mike for hanging in past
Sure.
the time that I asked him to hang in, and everybody else for continuing to ask questions. It's obvious that we really had a desire to get some information about pain and about as we get older and all that kind of stuff. So I want to thank him again. It was great. Thank you, Mike. And
You're
I'm
welcome.
going to let it